Anorectal Discharge Syndrome is the topic of discussion for this video. Hello everyone, myself Dr. Maddineni Srinivas, Dermatologist from Bharat. Let us begin the discussion without any further delay, and this topic was asked as a theory question in the DNB examination in the December 2025, and what was asked, it was simple anorectal discharge syndrome for 10 marks. So you must know what are all headings which you should write and under which what you need to definitely mention so that you are going to get good score. So we are going to see all the important points related to anorectal discharge syndrome. Watch this video till the end. So coming to the introduction and definition, and in short, what is it written as? It is written as ARDS. Please don't confuse this with acute respiratory distress syndrome. In dermatology, this is a sexually transmitted infection which is managed syndromically according to the National AIDS Control Organization NACO. ARDS is anorectal discharge syndrome, and it is going to primarily manifest as proctitis, inflammation of the mucosal lining of the rectum. And ARDS is highly associated with specific high risk sexual practices, MS, male, sex male, okay, and also it could be the females also who could be affected because of the men due to the peno-anal contact, right? And it acts as a significant facilitator because of the inflammation. There could be erosions, ulcers, raw areas which could act as a entry point for the viruses, especially the human immunodeficiency virus. Coming to the, whenever you are having a patient having the possibility of anorectal discharge, so you need to know what are all the high risk behaviors, practices which that individual may be having. So you need to remember and know 7 high risk behaviors. So these are going to be very important while you are even examining. Before the examination, you need to know about the patient and the different types of practices or different types of fantasies which that individual in front of you is or could be having. And these are based on the physical dynamics, that is what are all the objects or what are all the structures which are entering the anus, because of which there could be the manifestation of the anorectal discharge. So they could be penile, they could be hand, mouth, and the object, that is sex toys. So these are all the possible structures or medium which could gain entry, because of which they can transmit the infection from one person to another. So let us look at the penile based. So you need to know few important terms. These could be asked as 2 marks, 3 marks questions individually also. So penile based, we have this nudging, in which unprotected penile anal contact without full insertion is going to take place. And if there is partial entry, then we are going to call it as dipping. And it is receptive anal sex if it is complete entry, and it is going to have the highest risk of the mucosal transmission because of the microtraumas which could be produced. Next, we have the hand based. It could be simple entry of the finger into the anus, which is called as fingering, or it could be the entire fist entering into the anus, which is called as fisting. And practically you should be knowing that because the fist is larger, so there could be possible lacerations, shearing, which could lead to the damage of the mucosa, which again could act as a facilitator for the viral transmission, HIV transmission, and also the possibility of other bacterial infections also increases. Mouth based, we have the rimming, which is anilingus, basically the oral anal contact. It is highly possible that it could transmit the enteric pathogens from one person to another. Object based sex toys, sharing of the sex toys is also going to facilitate the transfer of the infective organisms from one person to another because of the fluid transfer. Now etiological classification, we have the 2 possibilities, one is the proctitis and the other one is proctocolitis. So microbial etiology of the anorectal discharge syndrome is divided based on these 2, and what is the basis of this? Again, the differences between the extent of the involvement of the rectum, anus, and also what are the organisms and what are the clinical features. So we are going to see one by one. In the proctitis, there is going to be inflammation of the rectal mucosa up to 15 centimeters from the anal verge, and the organisms are going to be Neisseria gonorrhea, Chlamydia trachomatis, Mycoplasma genitalium, and also herpes simplex virus. and the manifestation is going to be in the form of the discharge, which is going to be localized, and also tenesmus. In the proctocolitis, patients are going to have on examination, there will be inflammation proximally from the rectum into the colon, up to the colon. And what could the organisms? There could be Shigella, Campylobacter, Salmonella, Cytomegalovirus, and also Entamoeba histolytica associated with amoebiasis. Commonly associated with systemic diarrhea. Patients are going to present with clinically diarrhea. And also remember, if you remember Shigella, Campylobacter, Salmonella, these are also implicated in the SARA, EARA, enterically associated reactive arthritis, sexually associated reactive arthritis, right? So that is also important association which you can remember. Clinical features of the proctitis. So the clinical presentation based upon localized mucosal inflammation, edema, and secondary secretory changes within the rectum. So primary symptoms are going to be obviously the anorectal pain, itching could be there, purulent mucoid discharge could be there, and also there could be localized bleeding depending upon whether there is any shearing or laceration if it occurred. Tenesmus, rectal fullness, this is one very important symptom associated with proctitis especially. So in which there will be inflammatory swelling of the rectal wall which will stimulate the mucosal stretch receptors producing tenesmus. So what do you mean by tenesmus? It is a constant painful sensation of the incomplete evacuation. So though the person completely evacuates the bowel, whatever metabolic waste are there, but still they are going to get a urge, they are going to get a feeling, a painful sensation that they still want to evacuate the bowels. This is what is called as tenesmus. This is very important in the proctitis. And also mucus streaking could be one important clinical feature because of the hyper secretion. It could be, the secretion could be like we have already told, it could be serous, it could be mucoid, it could be pus, it could be blood. So if it is mucus and if it is forming a streak over the specimen, the anal stool specimen, that is also very important finding in the case of the anorectal discharge syndrome. Next, you need to know that in whom we can do the examination safely and in whom we should not do the examination. So this protocol you need to know. A methodical physical assessment is very much necessary to guide therapy, what treatment we have to give, and also prevent the procedural complications which could occur because of our intervention, that is iatrogenic damage. So we should be asking about the receptive history. We should, that is a reason why we have to know high risk behaviors, what happened before the anorectal discharge started, everything we should note down before starting the physical examination, and always establish if the patient participates in the receptive anal intercourse. And visually just try to inspect under a bright light the perianal and also perineal area for the presence of any ulcers, vesicles, excoriations, condylomas, or any visible discharge if it is present, even without any digital rectal examination or anoscopy. So DRE, anoscopy, proctoscopy, so these are perform a careful DRE and anoscopy to assess the rectal wall integrity. So how is the rectal wall integrity, whether it is normal or is it showing some abnormal changes because of the repeated receptive penile sex, right? And inspect the nature of the discharge, whether it is bloody, whether it is mucoid, whether it is pus, whatever, please record it. And you must remember that there are some absolute contraindications for the digital rectal examinations. So what are they? If the patient is having herpetic ulcers, so if you happen to see in the perineal area, there are some vesicles and the recurrent history of the vesicles and some ulcers, painful ulcers are there which are having polycyclic margins, probably it is herpetic, so you should not do the digital rectal examination. And also the patient is having anal fissures or the patient is having hemorrhoids. In these cases we are not supposed to do the digital rectal examinations, and this is because this to prevent the severe pain which the patient can get, and sphincter spasm can be observed if we try to perform the digital rectal examination, and there could be systemic bacteremia. If we do this, the pathogens may enter into the circulation of the patient. Next, coming to the what are the investigations which are going to help us to come to the conclusion. What is the diagnosis exactly? How to know that we are going to take care or take the help of these investigations. First one is gram stain. Perform immediate gram stain from the discharge whatever is there to evaluate the status of the organism. If it is gram negative intracellular kidney shaped diplococci, then it is Neisseria gonorrhoeae. We can also perform the NAAT, nucleic acid amplification test from the anorectal swab samples. So it is going to confirm if it is chlamydia or if it is Neisseria gonorrhoeae. Specific, so if you suspect the patient to have the LGV, lymphogranuloma venereum associated proctitis, then you need to do the specific genotyping for the LGV subtypes to know whether it is L1, L2 or L3. Right, and obviously in every patient who is coming with anorectal discharge, the screening should be done for syphilis and also for the HIV. So this is a must. With the management of the anorectal discharge syndrome, we are going to follow the NACO guidelines, National AIDS Control Organization, in which according to the syndrome we are going to give the treatment. So we will discuss this in a separate video. What are all the kits, what is the syndromic management, I will discuss this in detail in a different video. But here remember, kit number 7 which is black colored kit, kit number 8 which is brown colored kit. These are the two kits which are utilized for the anorectal discharge syndrome. Right. So the treatment of anorectal discharge syndrome utilizes targeted pre-packaged color coded kits designed to cover the most common, most important pathogens. So first one, standard anorectal discharge syndrome. Kit number 8 is going to be used, which is brown colored kit, which is going to consist of two medications. What are those? Tablet cefixime 800 mg, tablet doxycycline 100 mg orally given twice daily for a period of 1 week. Right. And if you see this carefully, you can observe one very important point, that if you remember, kit number 1 is having this medications which are going to cover the same organisms. So kit number 1 was having cefixime, which is targeting Neisseria gonorrhoeae, but instead of the doxycycline, kit number 1 had azithromycin 1 gram, only one tablet, that is going to target the chlamydia. But here that azithromycin is replaced with doxycycline. That is the only difference between kit number 1 and 8 if you have observed. What is the reason for adding this new kit? So previously kit number 1 was used in the anorectal discharge syndrome patients. Now why is kit number 8 being added? What are the changes done and why are they made? So I will tell you that just briefly. So the standard anorectal discharge syndrome was previously managed with kit number 1. But the problem is that increasing resistance and also high risk behaviors in the population has led to the introduction of this kit number 8. So that is the reason why instead of giving the azithromycin as a stat dose, though compliance is very good with the medications being given as a stat dose, so the patient can take in front of the treating doctor as a single tablet. Okay, one tablet cefixime, one tablet azithromycin, done. Diagnosis and also treatment is done at the same time. But because this anorectal discharge syndrome is very difficult to treat and also there is resistance and also high risk sexual behaviors are there nowadays which are rampant in the population. So we are going to give the doxycycline, though it is going to be taken twice daily for 1 week. Yes, definitely difficult compliance compared to the kit number 1, but still this needs proper treatment. That's why this kit has been introduced. Next is kit number 7, which is black colored kit, which is specifically used for the anorectal discharge syndrome because of lymphogranuloma venereum. Previously the kit number 7 used to have the azithromycin tablet along with the doxycycline, but now there is only doxycycline 100 mg tablet BD for a period of 3 weeks. So LGV, 3 alphabets are there, so 3 weeks is the duration which the treatment should be given. And these patients are going to present also possibly with inguinal bubo, right. and specifically this is going to target the chlamydia trachomatis serovirus L1, L2 and L3, right. And LGV proctitis, remember the patients who are having anorectal discharge are treated with kit number 8. Only one exception, if it is because of the L1, L2, L3, then we are supposed to give the kit number 7 black colored kit consisting of doxycycline BD for a period of 3 weeks. So, I hope this is very clear. It should not be treated with the shorter 7-day course of kit number 8. It needs longer treatment. So, that is why 3 weeks of doxycycline is used, right. So, just to summarize quickly, anorectal discharge, if it is the proctitis suspected to be LGV? If the answer is yes, we are going to give the kit number 7 black colored kit to manage the LGV proctitis. And if it is brown, the patient is not having LGV, then the kit number 8 or brown colored kit, cefixime 800 mg, doxycycline 100 mg BD for a period of 1 week is going to be used. So, I hope this video was helpful. If so, please do the like button and do hype the video, and if you are not yet subscribed to the channel, please do subscribe and do comment thank you sir if you found this video to be helpful. And that's it in this video. So, we will meet again in the next video soon. Happy learning. Bye bye.